Okay, let me move forward here and ask you, now this is not something I'm going to ask you to do now, but I'm going to give this to you as a homework assignment, and I will never check your homework, so you can not do this, and I will never know. But you can do it, and it's kind of interesting. It's a really good exercise. As we sort of think about the issue of countertransference in treatment, so I'm not going to talk about treatment strategies per se, I'm not going to talk about transference, I'm going to go right to countertransference, just to have a focus for this talk. That is supposed to be the focus of the talk. And when we talk about countertransference, what we're talking about are the feelings and thoughts that the therapist brings to the situation, brings to the treatment, brings to the therapy situation. Sometimes they're in response to something the client directly said in a session. Sometimes they're really coming just very much from the therapist's own background, and the therapist perceives it, perceives something that the client said that they didn't necessarily intend. But what we're talking about is really the therapist's own feelings in the treatment, and how those can get in the way of therapy. And so understanding our own feelings is important. We will experience feelings in response to clients who have trauma histories. There's no way of avoiding it. In fact, you don't want to avoid it. It's really good information. Knowing that you're feeling really irritated with this client, knowing that you're feeling really worried, incredibly anxious, knowing that you're feeling frightened, actually literally frightened because of something that links to your own history. These are all incredibly useful bits of information, right? Acting on your countertransference, that's where we get into trouble. That's where we get into trouble. Very often we will act on our countertransference, and I'll give some interesting examples of times I acted on my countertransference as we go along in this talk. But like as I said, very often we will act on our countertransference, but you want to become aware of that as soon as possible. So if you're finding yourself doing certain things that are uncharacteristic for you, or they're your Achilles heel, you want to really notice that early on and use that in the service of the therapy. So we'll talk about some of these in specific examples. One exercise that's helpful is for therapists to sit down in terms of getting in touch with what tends to really set them off. Think of a time when you were behaviorally out of control or shut down relative to you. So relative to your normal way of responding, what behavior of the other were you responding to? What were you thinking and feeling at the time? And what brought about resolution, if there was resolution? Like, did you just escape the situation and then just let a couple days pass and you couldn't even look at the person? Did you feel that you couldn't let go of the person? So you kept, you wouldn't let them go to sleep because you just had to figure this out, but the person couldn't handle that, and you found that unbearable. So think about that as a way of understanding what tends to get triggered for you when your attachment system is activated. Then, on the other side of the page, write down what emotions came up in doing the exercise. So what feelings came up for you as you, so and that should be helpful for you. It should be instructive in terms of giving some clues about the kind of countertransference responses that you might have with some clients. Clearly, you're not going to behave in the same sort of way with clients as you did in intimate relationships, but some of those feelings, you can find little remnants of those feelings, and those will be clues as to what tends to trigger you. So it's really important with our trauma clients, because all those same feelings of things that are difficult, painful, icky, upsetting, unpleasant about the world, all that stuff will get triggered for therapists when they're working with trauma clients. And it's interesting, in a lecture that I heard Anthony Manarino give a couple years back, he was talking about a client of his. And so he was talking about this idea of therapist anxiety with respect to trauma. So he's one of the people who wrote a very good book about trauma-focused cognitive behavioral therapy. And he was talking about a kid he was working with who I think was about 8 years old at the time. And the kid had been in about a year of therapy prior to seeing Tony Mannarino. And Tony was interviewing him, and he said to him, what happened when you were in therapy and you talked about, and your therapist and you talked about the sexual abuse? And the little boy looked at him and said, well, we never talked about the sexual abuse. And Tony said, you never talked about the sexual abuse? And the boy said, no, we never talked about that. And Tony said, well, why not? And the little guy said, well, I never thought my therapist wanted to talk about that. And it's really interesting. I mean, our clients will make attribute, and I don't know if the therapist did or didn't, but in this particular situation, the client made meaning of the therapist's not talking about it. So when we don't ask our clients, when we know that there's been a trauma history there, and we don't encourage or invite our clients to make meaning of it, to understand it, to use it in their lives, it's not just a neutral situation where they think, where they don't think about it. It's a message, and the message is, I don't think I can handle this, or this isn't a safe place to talk about this, or this isn't something that we're going to focus on. We're going to focus on other things. That's a bit of a problem. That's a bit of a problem. And Judith Herman, in her book Trauma and Recovery, talks about a couple of the cardinal sins of trauma therapists, and one of those is never actually getting to talking about the trauma with the client. If you just say the person will talk about it when they're good and ready, I can tell you there are people I've worked with for, I used to work, years, and they're never ready because it's too upsetting to talk about. I know you're gonna have questions about this and go, oh, but, what about, and we'll get to the but what about in a moment, trust me. But if we just stick with this idea of, it's important to give a certain message to the client that this is a place that is safe. This is a place where I'm interested in your trauma history. It's not that the trauma defines who you are. It's not that that's the totality of you. It's that it's part of you. It's part of you. And part of therapy is really about helping clients live alongside their trauma. Traumatic experiences, really painful attachment traumas, never fully go away in the sense that you get over a cold. But what they can become is this thing in your life that you can learn to live alongside. And that's a really big deal. That's a really big deal when we can help our clients reach a point where they don't have to continue to be plagued by their trauma history, where it's there, they know it's there, they can look at it if they want to, they can turn their attention toward it, and they can turn their attention away from it fluidly. It's coherent, it's part of their story. It's not the totality of their story, but it's part of their story. They're not too afraid to make it part of their story either. So that's important, and this is why we want to be able to reach a point where we can invite our clients to share their trauma story with us. The risk of not doing that, and I talk about this in my book, the idea of co-constructed avoidance. The client's too afraid to bring it up. The therapist thinks the client's too afraid to bring it up. He's not ready. The client thinks the therapist doesn't really want to hear about it, even though the therapist is open to it, but kind of gives a little bit of a vibe that they're not really open to it. And you get this mutual avoidance, this co-constructed avoidance, where they never actually get to it. They circle around the issue, but never actually land on it. And this can go on for months, it can go on for years. That's a problem. It's a problem because traumatic events continue to act on the individual. They continue to actually lead to trauma-related symptoms such as depression, anxiety, eating disorders, substance use. So we need to actually be able to help the client find a way to use their traumatic history in a way that no longer debilitates them. Okay. So that's an important piece. Having said that, I will also say equally problematic is when the therapist rushes to encourage or invite or even maybe push the client to talk about traumatic events before they're ready. So that's a tricky situation. And so, how do you balance these? There's no cookbook way of doing that. But I will say that the most important thing is to be mindful, for the therapist to be mindful and to ask themselves, is this person, to notice, I've been working with this person for 4 months or 5 months, I'm doing CBT, the whole therapy is supposed to really last 4 months, and I haven't asked about this traumatic event that the person talked about in the initial interview. What's going on with me? Just to ask yourself that. Maybe nothing, but maybe something. And if you ask yourself the question, then you'll start, going somewhere. It's helpful. Is there something about me where, with this particular client, I've worked with trauma before, and is there something about this particular client that's particularly provocative for you, where you feel something that leads you to be a little bit frightened of really addressing this issue? On the other hand, does this client somehow pull you into rushing into a trauma story? And I have this one client who, where I have an example of that. I talk about her in my book. I give her the pseudonym Anaya. And Anaya was someone who grew up in Africa. And just so you know, any client who I talk about in this talk, I am changing, identifying information for them. Okay, so just be aware of that. It's an important piece of information to know. So Anaya grew up in Africa and witnessed the death of many people, including her attachment figures, including her siblings, including her parents. She came to Canada, rebuilt a life for herself, really started afresh, and really did well until something happened where she was re-traumatized. She was driving on the 401 to visit her mom, who lived in a city about an hour away. And in visiting, her mom was, I apologize, her mom and she would drive back and forth to visit each other. She was in Toronto. Her mom this time came to visit her, was driving home and got killed in a motor vehicle accident. So the people who she saw die in Africa were her father and her siblings. Her mother was still alive and died on the 401 now when she was an adult. And she came to see me. So I tell you that story to tell you about my reaction, my countertransference. I was so drawn into her story. I found it fascinating. And I'd been doing therapy with trauma clients for years at that point. It's not like I was new to this, but I was writing everything down. I'm left-handed. I was writing everything. And then after about an hour, I let the session run over. It was now 65 minutes. I had another client waiting. It was, these are things I don't normally do, right? And I had this terrible cramp in my left hand. And so we booked the next session. She didn't show up to the next session. Contacted her. I never saw her again. So where did I muff that one up? How did I mess that one up? Well, a couple things, but I think the most important one for me is I got drawn into the events, to the story. I found the story so interesting that I was no longer being a therapist. I wasn't stepping back. I was rushing into this trauma story because it was so interesting and fascinating and so full of these, tidbits of information that are new and different, and they were, and I felt so compelled that I lost myself. I lost my role as a therapist in the process. And when you lose yourself in the process, then you're not doing therapy anymore. You're doing something else, but my job wasn't to be an interviewer. My job was to be her therapist, to find out a little bit about her trauma story, but her trauma story was not the totality of who she was. There are other issues, such as her relationships, her family, her work, all these things, and her symptom status that needed to be understood, where I let all that go and lost the role of therapist there. So rushing into trauma revelations isn't good either. And it's really important not to do that. Sometimes, as you can tell I'm talking about here, some of the patterns, one of them is that of therapist voyeurism. And I think that's kind of what happened here. I was a bit voyeuristic, so curious about Anaya's story. It was like I was a voyeur, right? That's not therapy. It's a juicy story. That's not doing therapy when you get caught up in the details of the traumatic event. We all have this potential to be a little bit voyeuristic. My wife is a psychiatrist, and she and I mentioned this because it has to do with something that happened in the story. She and I loved the show Breaking Bad. I mean, we watched it religiously, like we were there, 10 minutes before it's, we were so into it. And the last episode glued to our seats. Okay, so our son Aaron, who was 16 at the time, one of these episodes, and I don't remember what it was, but a murder happens, and it was really gross. I think what they did was they took the body and turned it into the sulfuric acid, liquefied it, and really gross, disgusting stuff. Aaron walks by the TV at the moment that that's happening, and he looks at it in horror, and he says, "You two are therapists. What's with you? Love watching shows about murderers. It's like, what's wrong with you?" Okay, he's managed, he's doing well, he's at U of T, I think he's adjusted okay, but not too traumatized. But it's kind of true. I mean, we both are, we sort of have these voyeuristic fantasies, and that's okay, that's all good, and that's all fine. And the fantasies are okay, and indulging the fantasies is fine as well. The issue is whether or not it then gets in the way of the actual therapy. So do the thoughts and feelings, the impulses, do they actually intrude on the therapy process itself? And that's the piece where countertransference actually is problematic. Another thing that we sometimes see, other than voyeurism, is this idea of the rescue fantasy. That's a common countertransference behavior with therapists working with trauma clients. The idea of, here's this vulnerable person who hasn't shared this with anyone, and this is really important. I'm so important to this person. So you tend to sort of think, sometimes therapists who work in trauma, if you think about your clients who are just there because of, I don't know, a spider phobia or something really kind of, it's not that big a deal, versus the clients who are revealing all these very personal things, who do you feel more important to? Now, chances are, I know that with the clients who have really vulnerable histories, those are the ones where I feel, okay, this is really important stuff. I got to really take this seriously. There's a sense of the special connection, or this idea of I have to take care of this person. Constance Dahlenberg talks about this in her book. As therapists and clients discuss great adversity, the painful events can become a shared burden. So this idea of, I'm sharing your burden with you. This is really important stuff. The members of the dyad often become bonded through their possibly secret or illicit knowledge of the trauma, and at times through their joint identification with the trauma. So the therapist and the client are connected through this identification with the trauma. The telling of the story intensifies this connection in cases where the members have a good empathic connection. Think especially of those clients where you really feel an empathic connection, and then wow, it can really feel like a very important sort of thing. And so sometimes we want to rescue those clients. We want to fix them. We want to take care of them. We want to do all these things to make them better. Well, we know as therapists, you can't make anybody anything. You can't do anything to anybody. Therapy is like being a good gardener. You've heard this metaphor, you can water the plant, give it sunlight, and the plant decides if it wants to grow or not. And if it wants to die, if it wants to grow, it'll make up its own mind. But you can't control it, and we can't fix our clients. We can create the conditions where they can heal themselves, absolutely, and that is the whole point of psychotherapy. And so understanding our countertransference is really important here. Sometimes there's a rescue fantasy with clients, particularly of an avoidant attachment. You had to really work hard. With avoidant clients, it's hard work. It's really hard. Very often they will push you away, dismiss the therapist. They'll be challenging to work with. They may come across as uninterested in the process. And so once the trauma story comes out, you've made that empathic connection and they're doing better, you have that feeling of, oh, we're getting somewhere, finally, or this is important after all. And then you can get into trouble, doing things like making special rules with these clients. With one client who I saw who came to see me when she was probably about 90 pounds. So this is a woman who I worked with who had very severe anorexia nervosa, and she was really struggling to make it on a day-to-day basis. And we did some very basic behavioral work, stabilizing her. I worked with her family a bit. She was in her early 20s at the time, so that she basically can survive. We had a safety plan, and this lasted for it must have been about 6 months of that kind of work. And then as we worked together, it turned out, in little bits, I got little trauma fragments, little hints that there's a trauma story there. And then it started to come out bit by bit as we developed a connection. And she became very important to me. So there was something about her where I think it was her vulnerability, maybe her childishness, something about her where I connected and sort of felt this, she's kind of like, it's like she's a daughter to me, or she's like, I've got to somehow fix her, I've got to take care of her, I have to help her. And that's fine in balance, but there was a way in which it went a little too far and I saw her as fragile. Now, that's a problem. And so then when she started missing sessions, I didn't, charge her for missed sessions, or she would come late for sessions. So I was starting to violate boundaries, or was letting her violate boundaries. She was testing limits, and I was not holding fast until I started to notice this. So there was a sort of situation where I was treating her as special. Now the problem with that is quite clear. It's disempowering to the client. When you start to treat the person as though they're fragile, they start to feel like they're fragile. So that's not going to work. You have to stay true to your own rules and boundaries. You have to stay true to the limits. And so when I started to notice my countertransference, I then became a little bit clearer about first of all, I noticed it aloud with her. I brought it into the session, and that was really helpful. And then I made it a point to be true to the limits that I normally set, to not treat her as so fragile, and that's been really helpful. But it took me noticing it. Hey, why are there special rules for this client and not for other clients? If you find yourself doing that with your trauma clients, check in with yourself. Why am I doing this? Is this my special client? Do I treat this person as fragile, as incompetent, as incapable? That's not good. That's not a very good message if I'm trying to help a person become independent and competent in their life. So let's take a look at some of the ways specifically that the countertransference can really get in the way. One is trying too hard, where the client gets you, you let yourself get drawn into trying to fix the person. And where do you see this? You might see it in your body language. You're leaning forward in your chair. If you catch yourself leaning forward in your chair, and you're not someone who typically leans forward in their chair, you find yourself feeling a little sweaty. Okay, what's going on? I'm getting activated. You find yourself getting into a mini argument with your... Mini arguments don't work. Many arguments don't work with clients, right? You can't convince someone through the scientific literature shows that blah, 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 blah. I've turned off, I can't hear you. Like, I don't care about the scientific. That's not why they're there. That's not why clients are there. They need to be able to, it's a trauma client, they need to be able to feel that it's a place that's safe enough where they can be able to be vulnerable enough to get help with this thing that's been causing them so much pain for so much of their life. You can't, in a frustrating way, try to undo the resistance. There is one therapist who I've seen who can work with clients where, you know, the client says something to them, and they look at the client squarely in the eye, and they say, that's denial. And the client, you know, shrivels up into a fetal position and says, oh, you're right, doctor. And that doctor is Dr. Phil. Yes. Dr. Phil. And he's the one person who can do this. And I don't know how he does it, but I know it doesn't work for me. Okay, it doesn't work for me. It probably doesn't work for most of you. Trying to undo the resistance. You're being resistant. Just knock it off. You know, smarten up. It doesn't actually work in real therapy. We know that it doesn't actually work. So when we all know it doesn't work, actually. So when we find ourselves trying really hard to convince, you know, we know that something's been activated. Maybe we're anxious. Maybe we're trying so hard because we actually are really worried about this person. Something has made us very anxious. The client is, you know, you're worried about safety, and it may be for very good reasons. But you're getting triggered, drawn in, and you're trying to force something on the person. Another countertransference pattern where we get drawn into our countertransference is the idea of becoming resigned, giving up on the patient. So this is almost the opposite response, where we pull away, writing the patient off. I mean, have you ever had, I've had this, the client who is really annoying. I mean, we've all had many clients like this, really annoying, and they call you, and they've canceled 6 times, and you've called them, you know, you've somehow rescheduled, and they call you, and they cancel, and what you do is you just cross them off your client list, and boy, that feels good, right? It's a good feeling. You write them off. This person isn't ready. This person doesn't give a hoot about therapy. This person just doesn't care. What I would encourage you to do, it's fine, cross the person off the list in that moment, and then once you've kind of calmed down and your countertransferences and you've talked with a co-supervisor, you know, if you do co-supervision with people, then ask yourself the question: what is getting pulled in me? You know, what is actually getting triggered in me with this person, where I feel like I keep wanting to just give up on this person. You know, I keep wanting to write them off. So what's getting triggered in you? There's some really interesting research that Mary Dozier did in the early 90s, where what she did, she gave adult attachment interviews. So this is an interview that activates the attachment system of adults. It asks about losses, separations, traumatic events, parenting, you know, things that parents have done, etc. So it really activates the client's attachment system. And she hooked clients up to galvanic skin response measures, which measure anxiety levels. What she found with the clients who had the avoidant attachment pattern primarily was that when you asked them about, you know, painful losses, upsetting events, when they were ill, who was there for them or not there for them, when they were upset, how did their, you know, mother respond, or father, or grandparents, etc. When you ask them these questions, clients who have an avoidant attachment style will minimize. Oh, it was no big deal, whatever, it was fine, you know, like, why are we harping on this, that sort of thing. But their anxiety scores, as measured on galvanic skin response measures, indicate a very high level of anxiety. So what does this mean? In contrast to clients with other kinds of attachment styles. So what does this mean? It means that clients who have an avoidant style don't not care. Like, don't you know, it's not that they don't care. It's that they're working really hard to convince themselves that they don't care. That's what that research shows. And there has been a lot of research to back that up. Other studies, more recently, by a researcher named Robin Edelstein in California, and other studies, which I won't go into in great detail, but corroborate. So these findings are consistently shown across a number of different kinds of anxiety measures and psychophysiological measures. These clients are working hard to not care. So the client who appears as though they don't care, don't buy into it too easily, especially if they have a trauma history. It's very hard to feel that vulnerable, to be that hurt by, if it's an attachment trauma, to be that hurt and to actually not care. And this is why we see so many trauma-related symptoms such as depression, anxiety, eating disorders, substance abuse, panic disorder, because of what we call disguised presentations. The traumatic events tend to come out in other kinds of symptom responses. Okay, and the last point I want to make about countertransference before I turn to some other things on this is the idea of, I talked about colluding. So, the idea of, so 2 more points. One point about colluding, when you collude with the client, like remember I talked about mutual avoidance. The client doesn't want to talk about it, you don't want to talk about it because the client doesn't want to talk about it, the client doesn't want to talk about it because you don't want to talk about it. And you get into this kind of pattern of everybody is not talking about the elephant in the room. And so that's a problem. Let me talk about this last point because I haven't touched on this at all. The idea of turning feelings into your countertransference into actually disliking or dreading the client. So clients who are avoidant, clients who have trauma histories and who are diagnosed with a variety of different kinds of personality disorders can be really tough to work with, right? I mean, we all know that clients who are constantly in crisis, who threaten to leave the therapy one week and then the following week get angry at you for not doing enough for them, who are up and down, who have difficulty with affect regulation, or clients who have antisocial tendencies with trauma histories or substance abuse, and you can't always rely on them, whether they're going to come in or not come in or stick to the protocols, etc. They can be really tough to work with, especially if they push the therapist away, get angry at the therapist, put you down. It's very easy to dislike clients like that. And I'm going to talk a little bit about Donald Winnicott. Again, he also wrote a very interesting paper. This is going back to the 40s. Old paper, really good paper called Hate in the Countertransference, where he says that the idea of disliking our patients is something that's pretty uncool. I mean, it's most therapists don't, he didn't say that in the 40s. I'm paraphrasing. Okay. Most therapists don't like to admit that there are clients that we really don't like, can't handle working, don't want to work with, that we just, because we're in this because we like people, we care about people. Therapists are empathic people fundamentally, and so that's a really challenging situation when your countertransference is telling you, I don't like this person. I'll give you an example of a case where, so this fellow, let's call him Paul. I saw him probably about 10 years ago. So I'm a prof at York University, and at the time I was seeing patients at a clinic on site. It was a medical clinic. That I don't see clients there anymore, haven't for many years. But so the reason I mention that is because this is a medical clinic, and there are always big lines. So Paul didn't want to wait in the big long lines. So, I mean, he was not covered by OHIP, obviously, because he was seeing me, a psychologist, and as you know, we're not covered by OHIP. And so he would cut to the front of the line, and he'd say, well, I'm paying out of pocket, so I shouldn't have to wait in line. So the secretary, the patient, the other patients in the hated Paul. I mean, they would like grumble about him. They complained to the secretaries didn't like him. They called him that Paul, and they would say, you've been seeing that Paul for about 8 months. How long does this therapy stuff take anyway? And honestly, I didn't really like Paul either. I mean, he was annoying. He was difficult, self-centered. He was very difficult to work with. About 6 months into our work together, Paul says to me, that he was at home for the weekend, doing some work in the garage. The garage where all that stuff happened. So where all that stuff happened? Yeah, I told you about it. He hadn't told me about it, but I said, well, remind me or tell me, what. And then he proceeds to tell me the story that up to then I hadn't heard. And the story goes like when he was in his early 20s. So when I saw Paul, he was in his early 40s. But when he was in his early 20s, he was at home. His father was in the garage doing some work, he thought. And he's looking at, he looks out his window of his bedroom, and he sees there's smoke coming out of the garage. He calls to his mom. He says to her to call 911. He rushes to the garage. He opens the door, and his dad is in the car. The exhaust, the car is on. The exhaust, there's a hose going from the car into the window. His father is trying to kill himself. Now this father, what I knew about Paul was his relationship. I knew his father had died years back, but I didn't know why. This was his, Italian father who came to Canada with $5 in his pocket, who built, started out as, working as a tile, someone who laid tiles, and then worked his way up, and then became a builder, and then a contractor, and then eventually a developer. This great father who was idealized, who he really looked up to, was trying to kill himself. Okay, so Paul drags his father out of the car, starts doing CPR. The paramedics arrive within 2 minutes, 3 minutes, something that couldn't have been more than that. They revive his dad, bring his dad to the hospital in the ambulance. His dad's in the hospital for a couple days. They release him, discharge him. Dad comes home. 3 weeks later, Dad successfully kills himself. Okay, so the reason I tell this story is because of what happened to me when I heard this. It's interesting that when I heard Paul tell this story, I suddenly liked him more. Isn't that weird? Like, why should I like him more? And it didn't happen instantly, but I noticed over the next few weeks that I was thinking about him. I never thought about him. I didn't like him. And I'll tell you, it's not like all of a sudden he became a nice guy. He was still it's not like anything changed particularly by him telling me the story. It opened the door a bit, but that's not where the therapy happened. What happened was the change happened in me initially. I was now able to sort of ask myself, okay, hang on a second. What is it about this guy that's so vulnerable that he can't handle being anything but a bully, annoying, that sort of thing to other people, where he has to push people away? What is he so afraid of? And once I was able to ask the question around his vulnerability, then I was able to find an empathic connection with him. And that's when therapy started. 6 months into therapy is when we actually, I think, said hello. And where I was actually ready to hear him. And then we were able to and he actually did make some really nice change. Work went actually very well at that point. But it took me realizing what I had been doing and sort of stopping and sort of challenging myself and my countertransference.